didn't already get on the sli.do, I'd like you to go ahead and do that. We're going to take a poll here at the beginning of the debate. So if you can use any device, just enter that address right here into any web browser, and then put in event code 3111. You can also submit questions. We're going to have some floor time for questions, so if you have a question for any of the speakers, you can submit it through that. I mentioned briefly the Benjamin Rush Institute at the beginning of the debate. The executive director, Beth Deeds, just flew in, and so she's going to take a quick minute here to tell you folks a little bit more about the Benjamin Rush Institute. And for any students who are interested in it, I've got some flyers up there by the food, so go ahead and pick one of those up if you'd like to talk more about it.
Hi, this is a great crowd. I'm so excited to see so many people here and interested in healthcare policy. As you know, we are living in an age where you cannot ignore what's going on in healthcare policy. And that's a big reason why Benjamin Rush Institute exists. There's a lot of stuff that as medical students you need to know and learn, and you have to concentrate just on the science of medicine, taking care of patients. But there's a whole lot to medicine that cannot be covered in curriculums, and that's healthcare policy and a lot of issues on medical ethics. Benjamin Rush Institute partners with medical school students to help them set up chapters on their campuses, or to bring, and then we work with them either as an official chapter or as an affiliate to hold lectures and have debates like this on a wide variety of topics. Things from end-of-life care, should you be able to sell your kidney, what's the role of physician leadership in an age of teamwork, how do we best create an environment that allows innovation to continue? We're having a debate in Washington, D.C. at the end of this month. What is the best way to address the needs of the poor? Is it through free markets and charity, or is it through government programs? So very wide variety of topics. It depends on who's interested in it. Colorado here has been our most active and successful chapter up until this past year. That's because we haven't had a student step up and say, hey, I want to work with you. I really need somebody who's interested to take that on, so that we don't have this kind of event not continue here at Colorado. So after the debate, come grab me if you're interested in learning more about it, or you can email me based on the information you get at up at the flyers.
Great. Yeah, my email is right over here, tyler.bar at UC Denver, and I'm the current president out of the CU branch of BRI, so go ahead and get in touch with me as well. Okay, without further delay, I'm going to welcome our debate moderator here, Annie Reid. Annie is a fourth-year medical student going into pediatrics. She's a member of the CU Unite, the urban underserved track here, and she's also our class co-president. Welcome, Annie. Thanks for doing this.
Okay?
Yes.
All right. How many of you guys are students in the audience? Raise your hand. And how many times have you seen the lecture hall this packed? Never, right? I'm so excited to be here and to see so many students and also faculty and community members here. One thing that Tyler didn't mention in my bio is that my qualification to be up here is I'm a super nerd debater, and I was a debater in high school, and that's what earned me this position today. So I want to tell you a little bit about how the debate's going to work and introduce you to the folks that we have here. So for today's debate, the resolution is going to be, is a universal healthcare system right for Colorado? And we have two folks speaking in favor of this and two folks in opposition. And so I will go ahead and read their bios to you, and each of them will have about 5 minutes to speak, to present constructive arguments and then also rebuttal arguments to the opposition. And we'll vote right before we start the debate and get sort of a feel for where people are sitting right now as far as where they stand, and then we'll do another vote towards the end. And we'll also have about 20 to 30 minutes at the end for you guys to ask the questions that you've posed through the website. All right. So you already heard from Senator Irene Aguilar, and she gave a little bit of her background, but I have some more here for you. She was born and raised in inner city Chicago, and was the first in her family to receive a bachelor's degree. She attended Washington University in St. Louis on scholarship and received her medical degree from the University of Chicago School of Medicine. And in 1985, she moved here to complete her residency in internal medicine. She's now worked for about 23 years as a PCP for Denver Health and serves on their board of directors. In addition, volunteers at Clinica Tepeyac, caring for the uninsured. She, like she mentioned before, really became interested in advocacy and public office in 2010 and now represents the Denver Senate District 32 in the Colorado General Assembly. And she serves on the Senate Committee on Health and Human Services and the Colorado Health Benefit Exchange Review, as well as the Judiciary Committee. So she's worked very hard on the legislation to expand Medicaid in Colorado, and most recently is the primary author on Amendment 69, which we just heard about. So thank you, and let's welcome her once more. Also joining us today is T.R. Reid, if you could raise your hand, who is speaking in favor of this resolution. He's one of the nation's best known reporters through his coverage of global affairs for the Washington Post, his books and documentary films, and his commentaries on National Public Radio. Reid majored in classics at Princeton University and served as a naval officer, a teacher, and in other jobs as well. At the Washington Post, he covered for Congress and 4 presidential campaigns, and he served as the paper's bureau chief in Tokyo and in London. He's written 8 books in English and 3 in Japanese, and has also written and hosted documentary films for National Geographic TV, PBS, and for the A&E Network. And his latest film is U.S. Healthcare: The Good News, premiered on PBS in 2012. He's also a member of the Colorado Coalition for the Homeless, the Japan-America Society of Colorado, and the Health Research and Educational Trust. Thank you, T.R. Reid, for joining us. And then for the opposition, we have Jonathan Lockwood joining us. And he runs the state's most widely covered free market nonprofit in Colorado, Advancing Colorado, which seeks to cultivate a culture of freedom and opportunity through public policy. The group's largest campaign against the Iran nuclear deal garnered global attention, and he was the first director of a free market group to reach out specifically to the millennials in Colorado, the Generation Opportunity, and served as the communications director for Coloradans for Real Education Reform, which led the fight against Amendment 66. He also served as the communications director for Compass Colorado, a conservative advocacy group, and was the spokesperson for Free Colorado. Also served as the press secretary for the House GOP. His prior work on campaigns for Congressman Mike Kaufman and Eric Weissman, and has also had a series of internships in music publicity for AEG Live and Tsunami Publicity. And his commentary has been featured in TV, print, online, and radio outlets in state, national, and international levels. And lastly, but certainly not least, because she is a CUSOM alum, we have Dr. Vecchio here joining us. She's a practicing physician specializing in radiology with a subspecialization in women's imaging, practicing since 1997. She became politically active after reading the Affordable Care Act and began speaking publicly on healthcare policy with an emphasis on market-driven ideas for healthcare reform. She's been on the radio, internet, and television, and had her own radio show. She's currently a healthcare policy fellow for the Centennial Institute and healthcare issues instructor for the leadership program of the Rockies. Thank you so much. All right, so before we get started and hear commentary from our speakers, we'll take a quick vote.
Are people able to get on to the website?
Yeah.
Okay. You should be able to vote at this point. Can everybody kind of see this? I mean, you can see it on your device as well. But, okay. So the question says, do you support the passage of Colorado Care in the upcoming November election? Yes, no, or undecided? We've got about 100 responses so far, so it looks like a lot of people are on there. During the debate, as you think of questions, you can go ahead and submit them through the same website, and we'll have about 20 or 30 minutes for those questions and if you're directing it towards a certain party, then please put the speaker you want to ask the question to in the question.
All right, we will begin with Senator Aguilar, who will speak in favor of the resolution. And for our speakers, T.R. Reid, yes, absolutely. Yeah. T.R. Reid will actually begin.
The senator yields her time.
Yes.
I will show all the speakers. We have our lovely assistant here, Bill, in the front, who has the timer, so you guys can see how much time you have left, but also we'll be cutting you off.
Okay.
Things get a little long.
This doesn't work. What do you think? Can you hear me?
Yeah.
Okay. Thanks, Amy. I'm grateful to everybody for coming. I'm grateful to the Benjamin Rush Institute for doing these Oxford-style debates. They're really fun. When I lived in Britain, I got to do Oxford-style debates at Oxford, at the Oxford Union, and I learned a couple of things. The first rule is you have to refer to the other side as the learned opposition. That's very important, and I will do that. And the second thing is, these debates don't take place in a vacuum. If you're debating some new idea or proposal, you have to look at it compared to what you've got now. And I think that's the key point in this decision today. When you look at Colorado Care, I bet my learned opponents are going to tell you all sorts of terrible things about Colorado Care. And I want you to ask the question, compared to what? Because unfortunately, they are stuck with defending the status quo. And the status quo, as Irene just told us, is not working. Let's take a look at what my learned opponents are going to be defending. We have a healthcare system in Colorado today that leaves 370,000 people with no insurance at all. Now, to me, that's morally wrong. I think we ought to provide for the least of our brethren, especially when they're sick. But leave aside the moral part, this is just a stupid way to organize healthcare, and I will be very eager to hear how they defend leaving 370,000 people with no insurance, because guess what? Those people still get sick. They still have accidents. And we don't leave them to bleed to death in the street when they get hit by a truck. We take them to the CU emergency room or Denver Health, where Irene works, and treat them. After an auto accident, 1 day of care in an emergency room after an auto accident easily can cost $750,000. And guess what? We all get stuck with the bill because those people don't have insurance. Wouldn't it be better to have a plan where everybody pays for health care, everybody's covered, and they don't stick us with their $1 million bills? I think this is better than the status quo. Another factor of the status quo is the Affordable Care Act. It's Obamacare. It was largely written by the insurance companies. It's a huge piece of crony capitalism for the insurance companies. They are making out big time, and they're gouging us. Every year since that law passed, they have raised premiums at 10 times, 12 times, 15 times the rate of inflation. Healthcare costs aren't going up that high, but they raise our rates. And while they're gouging us on price, they've been reducing their coverage. So that American healthcare insurance companies, the people my learned opponents are going to defend here, have introduced this reprehensible notion called the narrow network. And that means we decide what doctors you get to see. They have a network of doctors. You want to see Dr. Smith, if she happens to be on there, fine, they'll pay. If you want to go to Dr. Jones, they won't pay, even if Jones has been your doctor for the last 20 years. I argue it would be better to let the patient choose the doctor, the hospital, the lab, the chiropractor, the physical therapist, and not some narrow insurance company choice. Colorado Care, the plan we're supporting, outlaws the rationing of health care through narrow networks. And I'll be very eager to hear my learned opponents tell us why narrow networks with the insurance company picking your doctor for you is a better system. And finally, let's talk about cost. Guess what? There's no healthcare system in the world that's free. And Colorado Care is not free. It's going to cost, fasten your seatbelts, $25 billion in new taxes. Whoa, how could you defend that? Well, what's worse than paying $25 billion? How about paying $30 billion? $30 billion is what we paid last year. And as I said, the insurance companies raise that at 10 times the rate of inflation every year. So here's your choice. You can have a system imposed on us by Washington, D.C., and by insurance companies that are based in Indiana, Minnesota, Hartford, Connecticut, California, or you can have a system designed and run right here in Colorado by people you elect. You can have a system that leaves 370,000, 400,000 people with no insurance at all, or you can have a system where everybody pays and everybody is covered. So when your patients come to you and you need them to get a particular medication or procedure, you know it's going to be paid for and they're going to do it. We have a system where the patient chooses you, the doctor, the specialist, the chiropractor, whatever. That's better than the status quo. And finally, our system is vastly cheaper. So Colorado Care, it's not perfect. If there were a perfect plan, I'd vote for that one. Compared to the status quo, it's much better, so I urge you to support the resolution. Thanks.
Thank you very much. So next we'll hear from the opposition, and first we'll hear from Jonathan.
Can you guys in the back hear? It's loud enough? Okay. All right, sorry.
All right, can everybody hear me?
Yeah.
So I'm really glad that we're all discussing this proposal because Advancing Colorado first launched our campaign against the proposal last May because it started out with flash mobs for Colorado Care. They had a series of flash mobs across the state where they gathered petition signatures to get onto the ballot. So at these flash mobs that I went to, there were a couple of petition gatherers that told me that one, it's not a tax hike, and two, that you can opt out of this co-op that actually is not a co-op because everybody is forced into it. So, I mean, by definition, that's not truly a co-op. And so, they're telling people these things, and then in Colorado Springs, they're telling people that it's a repeal of Obamacare when it's actually a furthering of Obamacare. So, we really thought this is something that we need to jump on. And other free market advocates said, no, it won't get on the ballot. It did. And they say now that it won't pass. It may. So we're really dedicated to fighting this proposal. One of the big things about this proposal that is being touted as a reason to vote for the proposal is that there are no deductibles. At the last debate up in Frisco with Senator Aguilar, we found out that there may be in the future deductibles created by the Colorado Care Board, which initially is unelected. We also found out that seniors will be paying into this system even though they've already paid into another government system. And so Senator Nicholson, said that the thing that seniors will be getting out of Colorado Care is feeling good about paying for other people's health care. So there's a lot of mixed messages that come out of the campaign with the fact that people are saying it's not a tax hike, and it certainly is, based on the cost savings projections. The Economist, when he was interviewed by the New York Times, Friedman, he said that the details are not really his problem. That's a great thing about his job. So it's kind of like a bad customer service phone call where you get transferred around from one person to another. So when you ask the politicians for details about the proposal, they direct you to the Colorado Care Campaign, and the Colorado Care Campaign transfers you to the Economist, and the Economist transfers you back to the politicians. So there's a lack of information that's really getting out there. Another problem with the proposal is that the proposal is not truly binding. The elected board will end up deciding what is and what is not health care in Colorado. And so there's not a 100% guarantee that even if you vote for this and for all of the details in the plan, that that's actually what we'll end up getting. I think that's really concerning because healthcare is really important to people, and when people are in a healthcare crisis like we are, a lack of guarantees isn't very comforting or very solid or concrete enough to vote for a $25 billion tax hike. The other thing that I think is really important about this is that this is not the partisan fight that so many people have said it was going to be. The state's top Democratic leaders, including Governor Hickenlooper, Senator Michael Bennet, Congressman Jared Polis, they won't support this, and I think there's a lot of reasons why. We have to get past partisan conversations and find a solution that people from both sides of the aisle agree on, not one that both sides of the aisle completely disagree on. And so I think that, I'm really looking forward to questions because, there's so much to talk about this. And I think there's very concerning things with the fact that former Governor Dick Lamb, who's on the board for the organization behind this proposal, once said that the elderly have a duty to die. And so when you have people that say things like that behind a healthcare proposal, who says that doctors take the Hippocratic Oath too seriously, I think we really have to look at who is behind this and who's pushing this and what their philosophy on human life is, because this can have a very negative impact on the delivery of care and the actual provision of healthcare treatments that are a matter of life and death. So that's about it for now, and I appreciate everybody for coming. It's a very packed room.
So now we have Senator Aguilar.
Thank you. I haven't been to Grand Rounds in a long time, but I remember when I used to go to Grand Rounds, it would always start with a case report. And so I want to tell you about a case report. When I first met patient VF, she was a 40-year-old receptionist with diabetes. She did not have insurance. Once a year, I would refuse to fill her prescriptions unless she came in for a checkup. At these visits, we would find that her diabetes was not in control. She would apologetically ask which of her medications were most important because she could not afford all of them. By the age of 50, she developed renal failure, and she required dialysis. At that point, she qualified for Medicare. She felt weak going to dialysis 3 days a week, and her workplace could not accommodate her frequent absences. VF filed for disability and lost after she lost her job. After exhausting all her savings and resources, she qualified for Medicaid and went on to get onto SSI. Over the ensuing years, VF lost a limb to amputation. She developed coronary artery disease, had stents, had CABG, and by the age of 62, she died as a result of complications of her diabetes. This is my motivation behind Colorado Care. Working at Denver Health, seeing day after day the human costs of a system that says, get it if you can afford to pay for it, and if you can't, we'll be here to catch you when you hit the ground. Because sometimes when you hit the ground, we can't make you better enough to come back. And I am not embarrassed to say that as a physician, I think that access to healthcare is a basic human right. I think that it's shameful that the richest country in the world does not guarantee that right to the people in our nation. And I am frankly embarrassed that leading politicians are not willing to call us out on that. To me, that further shows the corruption of money in politics. And even at a state level, I can tell you that corruption exists. There are national groups pumping money into our state to defeat Colorado Care because money works. Americans for Prosperity is funding a large part of the opposition. Businesses are concerned about their bottom line, but if they were to just sit down and honestly look at what do they spend right now, national data suggests they spend, businesses that do provide health care spend 10 to 12% of payroll on health care. We are going to drop that to 6.67%, and we're going to allow our providers to actually practice medicine and not have to waste so much of our energy and time figuring out, is this a benefit that I can get for you, or is it not? And if I can get it for you, what hoops do I need to jump through to get those benefits for you? And you know, one of the unfortunate things I found out when I entered the legislature is these little games we sometimes play to try and help our patients out to get what they really need to manage their diseases actually could be labeled as insurance fraud. So here I was trying to help people get what they needed to manage their disease, unwittingly practicing insurance fraud. I think every life is sacred. I think every person deserves a chance at living a healthy life. I think when you start out, unfortunately, perhaps in an unwanted pregnancy or in a wanted pregnancy in a family where the income does not allow your family to provide you the social economic status you need to get ahead, that does not make your life any less valuable. And so as a physician and as a humanitarian, I would ask you to look inside at your conscience and think about the future of the practice of medicine and whether you want to be worried about who's going to pay for what, or if you want to be part of the team that says, you know, for this patient in the end, we allow them to keep working, we allow them to maintain their dignity, and we allow them to control their disease if we provide access to this health care for them. And maybe for this patient, they don't really need that. They do come in too much, and we do need to start charging them some co-payments. I do want to, as a last statement, just say that the amendment clearly states that deductibles are not allowed, period. Co-payments could be introduced if necessary, but no deductibles ever. Thank you.
Thank you very much. And now we'll hear from Dr. Vecchio.
Just want to remind everybody to submit questions if you have any for the SLI that you have.
Hi, everybody. It's so great to see this many medical students. I thought maybe on the first day of medical school you would have been here, right? This might have been this fall, that young. I would like to thank Benjamin Rush Institute and definitely all of you, as well as my fellow panel mates here for coming today, because this is an important discussion and it really affects you all more than us old folks. So it's really important, and I'm really glad that you're here to talk about this. One of the problems, and I hate to contradict T.R. Reid, he's kind of a famous guy. I hate to contradict him, but I am not here to support, and Jonathan and I are not here to support the status quo. We are not here to support PPACA and what it has done to our healthcare system, which is a travesty. We are not here to say, let's go back to the way the healthcare system was before Obamacare, because that was a travesty. We think there are other options rather than keeping it. We keep going down the road to more and more government or more and more other person involvement in our relationships as doctors with our patients. The problem with the system inherently that has developed over the years, as Dr. Aguilar described, is that we have now separated the person getting the care and the person giving the care from the person paying for the care. Once somebody else is paying for something, it messes up the system. Either people are going to use too much care, or the person paying for the care is going to try and control this relationship. The doctor-patient relationship is being controlled by our government, our insurance companies, lobbyists, the American Hospital Association, Trial Lawyers Association. All these people now have a financial stake in what happens between us and our patients. In my opinion, that's the problem that we need to address. And by turning everything over to a 21-member, initially 15, but eventually a 21-member panel of a board of trustees, that we cannot, you can't hold a recall election to get rid of them. They can get rid of each other and then appoint somebody else to take their place. But we can't get rid of them. We have to wait out their term and hold an election 2 or 3 or 4 years down the road, and a lot can happen in 2 or 3 or 4 years. So we're going to give $25 billion to these 21 people, and we're not even sure what they're going to do with it. We honestly don't know. The legislation itself, the amendment is like 12 pages long. There's a lot of information in there. It refers back to different state statutes and things like that, but it's not the whole story. This board of trustees is going to have immense power over deciding what you get paid for as a provider, what care a patient can get, how structures are going to be set up, how they're going to spend their money. There's going to be common medical records across the state, which, in some ways I think that's a terrific idea. The devil's in the details. Working in a hospital, I worked in hospitals, obviously I worked at the VA and Denver General, we call it Denver General, Denver Health, we call it the doghouse. Denver Health and Hospital, University Hospital, the VA. I worked in all those systems during my training, just like you have. Some of them work, some parts of them work, some of them really don't work very well at all. Now, the idea that we're going to put a lot of power in the hands of a very few people, and they're going to decide what kind of a system is going to work. Medical records is crucial. It's so important to have that be between the physician and the patient. And it's only the people that absolutely need to see that information should be able to see it. So that's one of the things that bothers me. I have T.R. Reid's book here. No offense, but I got it used.
That's bad.
But there are a lot of reasons why. He talks about a lot of universal care systems across the world. And he also talks about why a lot of them don't work. And some of the things that don't work about them are really important things. So hopefully we'll get to touch on those. And I would love, before we're done, to give you some ideas that I have and that many of us have come together, including Dr. Haynes, to come up with ideas for market-based reforms that gives the power back to the patient and to the physician. We're dealing with a small group of people, a subset of people who don't get adequate care, don't have access to care. Let's deal with those people rather than changing the whole system for everyone. Thank you.
Thank you all so much for sharing. We're going to go ahead and ask some of the questions that come up. Please stand up.
So depending on the question, we can kind of leave it up to the speakers, but if one side especially wants to field it and the other side doesn't, that's okay. Otherwise, we'll give each side about a minute or so to respond to the question.
So the first question that we have is what happens to all the private insurance companies in Colorado and the people employed by them if Colorado Care passes?
Thank you. You know, interestingly, I actually reached out to the Colorado Department of Labor and Employment to say how many people are insured in the medical insurance market and this are employed. And they actually said it was only 4,400 that live in the state of Colorado, which surprised me. I had thought it would be much higher. But the fact of the matter is there are many functions that insurers provide that will still be necessary. There's still going to be, hopefully through a smart card, a way of bills getting paid. There's still going to need to be data analysis. Most medical providers don't have the business expertise or desire to figure out, okay, how do I go about arranging to hire a nurse or hire a social worker? So a lot of those skills in terms of how do you actually run a practice will need to be done. I think clearly the departments that do marketing will be cut dramatically down because while Colorado Care doesn't forbid the sale of private insurance, it'll sort of be like public-private school where the demand is not as high as it used to be.
Bill's very, very on it. Yes, absolutely. Go ahead.
Just briefly, I think I didn't understand it a long time ago either, but a lot of Medicare, even though it's paid for by the federal government, a lot of the administration of Medicare actually occurs on a more local basis through private insurance companies. So one of the questions I had also was, will Colorado Care, and we honestly don't know because that's kind of up to the Board of Trustees to decide, will Colorado Care use the private insurance companies to administer their product, Colorado Care? So, or will they have a central administration that will do everything? I know it says in the legislation something about a single billing office or something, but I don't think we know what the details of that are. I'm not here to, like I said, I'm not here to prop up the insurance companies by any stretch of the imagination. They're the bane of our existence as well. But, you know, I think the insurance companies, it seems like we don't know what's going to happen with them or what role they may have.
The next question posed by our audience is what kind of coverage for mental health care will be provided?
Now that I know he's really going to cut me off at 1 minute. You know, one of the interesting things is I talked about the prioritizing the care of the medically complex patient, and as some of you may know, Denver Health got a grant to try and do that and really focus on decreasing readmissions of the medically complex patient. And one of the first things they did with that grant was they decided they were going to need to hire more mental health providers because, not surprising to you, many of the people who are repeat offenders ending up in the emergency room all the time have substance abuse or mental health issues. And so I think paradoxically that in our quest to save money in healthcare by cutting benefits for mental health, we led to an increase in total cost for healthcare. So mental health has complete parity, and the value of that in the management of the medically complex patient will be recognized.
Next question is, will Colorado Care revenue be permanently TABOR exempt, or will it be placed in the general fund and contribute to the cap in future years?
So one of the pushbacks we frequently get is, why did you put Colorado Care in the Constitution instead of in statute? And frankly, we had to do that because of TABOR. Under the terms of Colorado Care's amendment, it is perpetually exempt from TABOR. And so it will always be separate from that. And don't tell my fellow legislators I told you this, but I really don't want them to have access to our healthcare trust fund. And by doing this, they will not have access to that healthcare trust fund.
TABOR, how many of you know what TABOR is? Wonderful, I'm impressed. TABOR exists for the benefit of every taxpayer and every person in Colorado. Okay, it's in our best interest for TABOR to be protected at all costs. TABOR, not all costs, but for it to be protected, because that protects us. So this law in the legislation says it is not subject to TABOR. Whatever percentages for payroll and so forth that they're mentioning now, every year those can go up. Every single year. And people can vote to increase payroll and non-payroll taxes on people even when they're not paying into the system. So people who aren't paying anything can vote to have somebody else's taxes increased every single year. So we don't know, I'm not seeing a cap anywhere on how high these things can go, and at what point do we say this isn't working? That's a huge concern of mine.
The next question is, how would Colorado Care affect provider reimbursement?
Thank you, and I'm going to be a politician. So we are the only state in the nation that has TABOR. We have the fourth best recovery, and yet we rank 49th in funding for education. TABOR has really strapped our ability as a state to provide what we need for our people. TABOR really benefits people who are opposed to taxes. In Colorado Care, though, your rates are guaranteed until there is a vote of the people. So although TABOR is exempt from TABOR, the money doesn't count against that. Your rates cannot be raised without a vote of the people. And so that certainty is there for you. And I already forgot what the real question was that you asked.
How will Colorado Care affect provider reimbursement?
So, the truth of the matter is we will be the potentially the only state in the nation that has this. And can you have a healthcare system without healthcare providers? In spite of what you hear from the insurance companies trying to cut your payment rates, I think they're undermining themselves. We need providers. We need the best providers if we really want to make an impact on medically complex patients. We need to pay people really well for doing that and pay their team as well to help make that happen. And so it will be a negotiated rate. There will be the opportunity to increase rates in order to get people to do certain types of practice, like perhaps nobody wants to live in Lyman, but whatever it might be. But the intent is that providers get at least 133% of Medicare.
Can I read about that? Again, this is not written in the law. This is up to the Board of Trustees, and that can change over time. In Dr. Reid's, Dr. Reid, you're going to have an honorary degree, but in Mr. Reid's book, he talks about how physicians are treated, and I met with one of the Japanese health ministers a couple years ago because they came over here to see what ideas we had that they might be able to use for their system because their system is having a lot of problems. In Japan, each primary care physician sees between 100 and 150 patients a day.
Whoa.
A day. That's not the only one. There are several examples of different countries where physicians are seeing 70 to 150 patients every day. You know how much time that gives you with your patient? And you want to talk about quality care, you want to talk about patient education, wellness, promotion, and preventing people from getting ill. Japan prescribes more medications than almost any country in the world, if they're not at the top. Because when you have 3 minutes with a patient, you're just going to, here, take this, and come back later. And so it's really crazy, and this is the kind of pressure that you folks are going to have to look at. Their reimbursements are low, and the only ways that they can control costs are to increase the taxes to decrease reimbursement to providers, and to limit the scope of services that are available for patients. That's it. Those are the only ways they can control costs. So something's got to give when it doesn't work. And when people can have access all they want, they can go to doctors anywhere they want, as often as they want, for whatever they want. You know, it's kind of Katie bar the doors. You can't have it all. So, you know, just being realistic here, this is going to affect you all in your careers a whole lot.
Do we have
So I wanted to say two things. First of all, that the productivity issue. You know, one of the things you might have noticed on that slide is how much more the United States spends on healthcare than the other countries. So we're not proposing cutting how much we spend on healthcare. We're proposing changing how we collect those funds. Secondly is because we will be a state that is implementing this, every provider in the state could choose to leave if we did what Dr. Vecchio is suggesting we might do in our state. And I can guarantee you that would undermine the focus of the entire system. And thirdly, as opposed to our system right now that chooses to save money by cutting provider rates, we know that research shows, and interestingly in Denmark, that they went from 150 hospitals to 75 by implementing patient-centered medical homes. So by having your physicians as part of your team, helping you figure out how you control costs on that 75% cost drivers, those 15% of patients, you have the ability to have them have shared savings from helping control those costs. So I would not imagine seeing that coming unless we hope for our system to fail.
Thank you. Our next question is for Jonathan Lockwood. When you say the Colorado Care Board would make decisions about what is healthcare, how is this different from what an insurance company does?
Well, it's not a whole lot different, and when you look at it and you see that some people are saying, well, an insurance company gets to make these decisions, we should just take it away from insurance companies where there's a lot of people making decisions to a 21-person board making decisions. You're replacing one problem with another problem. And so I think that we have to get past this idea that if you don't like this one proposal, that you just want to keep everything the way it was before. And I think that's not, it's just not really fair for a conversation about reforming our healthcare system. And having an apocalyptic view of our healthcare system isn't going to get us anywhere. And I mean, when you have emergency crisis situations, waiting years and years for this plan to get into effect after we pay money into it and have to wait for the goodies, people are still not going to be getting the care they need for X amount of time, however long it takes for this Colorado Care Board to figure out how to make it happen. I won't be a politician.
Insurance companies make decisions now. They determine how much they're going to pay you. They determine whether they'll pay you at all because they set these narrow networks. And guess where that decision is made? It's made in Minneapolis, Minnesota. It's made in Indianapolis, Indiana. It's made in Hartford, Connecticut, and California, where those insurance companies are. You have zero control. In Colorado Care, not only will you be able to elect the board, we think doctors will be on the board. We don't think that the health profession is going to let that pass. So we will have control, and this is a fundamental difference. Jonathan thinks it's a good thing that Minnesota and Indiana and Hartford, Connecticut dictate our health policies. We think health rules in Colorado ought to be made in Colorado by Coloradans, elected by Coloradans, and that's why Colorado Care is better.
So no, I don't think that Minnesota and Indiana should be ruling our healthcare system. I think
they are.
So I think we have to get past. Right, but this is not going to change. It's just going to change the location of where people are making decisions. So you're going to have a Colorado Care Board, completely unelectable, or unelected. Well, they might be unelectable, some of them, but a completely unelected board making these decisions. Initially, they're not. Initially, they're appointed, and so you're going to have an appointed board making decisions, and they're not accountable to any oversight agencies. They're not accountable to the legislature. They're not accountable to the governor. So you're going to have a completely imperial healthcare bureaucracy directing all of these decisions, and we're supposed to celebrate that it's located in Denver rather than in another state. I mean, the problem is that so few people are making such important decisions, and we need to break that system down so that more people are involved in the decision-making process, not less.
Yeah, I get to make the rules, right?
You know, I've been looking at other states. Many states would like to see us provide health care for everybody. We're not going to do it nationally. It's going to happen state by state. I was in Oregon, and here's their plan. I loved it. They have a 2-sentence constitutional amendment. First one says, everyone in Oregon who needs health care shall have it. And the second one says, the legislature is mandated to effectuate this guarantee by January 1st of such and such. I love that. It was so simple, right? And I came home and told my pal Irene, this is great. And she said, oh God, don't let the legislature get anywhere near it. They'll mess it up. And that's true, they would. It's a virtue of our plan that we have an independently elected board. You will elect it. Doctors will be on it. That's better than letting the legislature and the governor screw it up.
After it's appointed by the legislature and the governor.
No, it's elected by the people.
No, it's not. Initially, it's appointed.
Yeah, initially they are political
So-
appointees based on,
By the people they say
Democrat.
they don't trust.
yeah, exactly. But I think the other important thing to note, to go over this lack of accountability. So we're putting $25 billion, that's equal to the state, Colorado state budget, the entire state budget, $25 billion in the hands of 21 people. And they're collecting taxes, right? So they're collecting taxes, they're going to take over workman's compensation, they're going to take over federal and state money for Medicaid. They may do a Medicare plan and they'll be getting federal money for that. Insurance companies now are overseen by the insurance commissioner of the state. The Medicaid is overseen by the insurance commissioner of the state. The idea that we're putting all this money and all this power into a very small group of people and they aren't accountable to anybody until it's time for the next election? Wow. I mean, that's a great job.
So we're gonna, I'm gonna move on to the next question. So we're gonna step away from the Colorado Care Board, and the question that the audience wants to know the answer to is, if this is not the best answer, what is, for those opposed to Colorado Care, what else is being put forward to ensure the best coverage and care for all Coloradoans? Go ahead.
Yeah, thank you for asking that. In just 1 minute time, it's a long list. Get rid of the state insurance mandates. More things that everybody is required to pay for that they may never use. I have to pay for maternity care and pediatric coverage. A single man has to pay for maternity care. It's ridiculous. Let me pick and choose what I want coverage for. We're talking really, the gap and the reason for this whole bit of legislation is that, like the patient that Dr. Aguilar described, it's terrible what we do to people who are in that middle with chronic disease. Concierge practices right now, a private practice, they do great. They make a good living at it. They don't have to see as many patients. And these patients, they specialize in people with no insurance and chronic conditions, pre-existing conditions that can't get insurance elsewhere. You buy a membership into this primary care practice, maybe for a family of 4, it's like $125 a month. Unlimited office visits, free chest x-rays, EKGs, certain lab tests are going to be free. Other lab tests are $4. I can go on and on about this. I have a whole list, and also I have a policy paper that I wrote 2 years ago on Colorado. I'll have them out front, or if anybody wants it, why don't you come down here if you want one. It talks about all that stuff.
Sure.
I just wanted to say that the concierge doctor sees that patient and now they need to see a pulmonologist and their out-of-pocket deductible is $2,500. Or they see that patient and they're diagnosed with rheumatoid arthritis and they prescribe Humira, which my sister takes, and has been $1,800 a month for the last 10 years. And then we run into those folks getting nowhere with their health.
Well, I think the alternative to Colorado Care is quite clear. The only one we've got is the system we're stuck with now. Washington, D.C. can't fix anything. The legislature has tried 20 times and never come up with anything. Our choice in November is Colorado Care or the system we're stuck with now, and I noticed that my learned opponents didn't even want to defend that. So let's move on to something better.
I never got to finish all the ideas, obviously, in 60 seconds. Obviously, the concierge is not the only answer. This is a small group of people in our population that really need help. I would say, let's allow the market, let's allow people to make more choices for their health care, get rid of the insurance mandates, encourage health savings accounts, block grant money to the state for Medicaid so we can decide as a state how to spend that money and who will qualify and who won't qualify for that, which may cover a lot of these patients. And the other thing, let's definitely subsidize care and premium prices, premium costs for that subset of people that really need it. Absolutely, we are here, we need to take care, I agree, we have a moral obligation to take care of people who need our help. Let's focus our efforts on subsidizing those people rather than changing the life of every single person in Colorado.
I'm actually, okay.
I just want you to remember that slide that I showed you, that those people who need help represent only 15% of our population, and they require 75% of our healthcare dollar, which means that we need to find a way through charity to pay $22.5 billion a year in healthcare for those people.
The next question we have is who will have access to the healthcare system in Colorado under Colorado Care, undocumented individuals, tourists, etc. Who else would have covered?
We're going to cover every resident of Colorado. There may be some residency requirement. I think there's a one-year residency requirement to get in-state tuition at CU. There are different rules in Colorado. There might be some. There'll be some residency rule that we'll set up. But once you're here, living in Colorado, if you get sick, we're going to take care of you. Now, including illegal aliens? Yes, because guess what? We care for them now. Some guy's working on your yard or working on your roof and falls off. He goes to Denver Health or CU emergency room, and we care for them now. Now, they're going to be paying for their care. So yes, everyone who lives in Colorado will be covered. And then we can show the United States, finally, that it's possible to provide health care for everybody at reasonable cost. This is something our country should have done decades ago.
First, I want to hit TR for using the word illegal aliens. The proper word is aspiring citizens. I want to tell you that there are at least 4 reasons why people who are in our state undocumented should be covered. I think the first is a very basic public health reason. If they have a public health illness, it affects the health of our entire population. The second is a cost reason. If we're going to cover them for their complication when they show up in our emergency room, we should cover them to try and prevent that complication. The third is that there's research that shows that they pay $11 billion in taxes and get no benefit for that, so this would allow them to get benefit for the taxes that they're paying now under somebody else's name that's going to fund your Social Security Trust Fund. And finally, because it's the right thing to do as a humanitarian.
So I think this question points to part of what I've been really hitting on this whole time, is that we don't really know what Colorado Care will be with this proposal. If you vote yes on this proposal, it doesn't mean that it will actually end up being what you're voting on. So the term resident is not defined in the proposal, according to State Senator Jeannie Nicholson at the last debate. However, according to the Colorado Care campaign, resident refers to many things. It refers to people who intend to move to Colorado. It refers to aspiring citizens. It refers to anyone and everyone. So Coloradans are going to pay $25 billion, and that system is going to be a free-for-all of health care for anyone, anywhere, anytime. And that money's supposed to last for everybody? I mean, how is that even possible? It's like opening up a buffet and saying, well, anybody can come and eat for free. The food is going to be gone. So you can't have this, it's not this everlasting well of money. And so that's why rationing of health care will happen, or future tax hikes will happen.
Just real quick, I see a lot of Medicaid patients, and we work through some of the clinics through which Medicaid funds run. Through a clinic, they see the patient, and then the patient comes to my office, and that clinic reimburses, for the care. They run, and I do breast care, so I find breast cancer, mammography, breast biopsies, that sort of thing. The money runs out almost every single year in March. Runs out. This is Medicaid money, runs out. So those patients that need care either have to find it some other way, which isn't right, but the bottom line is the money can run out, and it does run out already for some of these systems. So don't think that it's a bottomless pit of finances.
All right, and we have one last question before we wrap up and we'll go again. And that question is, what have we learned from Vermont's experience?
That it's a failure.
Vermont tried something almost identical to this, and they had, famous economists and so forth that were working on their plan. They, in 2010, when Obamacare was passed, they knew about Section 1332, and right away they said, we're going to do single payer in Vermont. 4 years later, they gave up because they couldn't make the numbers work. How many tens of millions, if not hundreds of millions of dollars were spent over that 4 years to figure out that it didn't work? This, and it's almost identical to this. And honestly, I don't know what the difference is. If there's other than there's and part of the problem was they were depending on a lot of federal money, federal grant money and so forth that didn't come through. Well, you can't change an entire state's healthcare system for something that may or may not come through. If your system depends on somebody else paying a huge amount of money and it doesn't come through, it doesn't seem like it's very well planned.
Thank you. So Vermont started with this ideal and then said, how are we going to pay for this? Colorado Care started with how much money do we need to run healthcare in our state? What kind of healthcare can we cover with the kind of healthcare we want to run? And then let's take a look at how much money we're getting in from the federal government. Let's take a look at what our revenue is in taxes from our state. And that's how we set the 6.67 and 3.33% was based on reaching that number. So I'll tell you a couple of things about Vermont. First of all, they're a population of about 500,000, so they're a tenth of our size. Secondly, did you know that about 30% of the people in Vermont get their health care outside of Vermont? Because as you know, it's about a 30-minute drive to Boston, depending on where you're living. The third thing about Vermont is they actually already had Medicaid expansion, and so they did not get that funds that we got for Medicaid expansion in our state. So the amount we actually get from the feds that I can get from our large council is known. And the final thing is that Vermont tried to say, well, not everybody really has to pay in. If you're a large employer, if you're biz, you don't have to pay in. We are putting in an across-the-board premium tax. Everybody is paying in.
Thank you all for coming and joining us today and speaking your thoughts and your argument. Thank you. All right, we're going to do one last poll.
All right, let's see. There you go. You should be able to vote now. While you're doing so, I'll just go ahead and talk a little bit so we can get everybody out of here on time. I'd like to take another opportunity to thank all the speakers for coming. I really appreciate everybody taking the time to come out here and share your thoughts and opinions on this important issue with us. And thank everybody for coming out to hear what they had to say. We will await the results here. It looks like we have 138 in. That's about what we had on the last poll.
No, you had 148.
Yeah,
We're almost there.
Yeah, we're getting there. Okay. So as these results trickle in, I think we have a pretty clear decision from the audience. It looks like the initial poll, if I can pull up those results still, I think. Yeah, so the initial poll showed about 59% yes, 1% undecided, and now we've got about 74% that would support the amendment and 13% undecided. And the no side appears to have gone up about 4% as well. So, looks like some people changed their minds, some folks are still undecided. It's definitely a complex issue and one that will be on the forefront of all Colorado voters in the next election. I appreciate you all coming out. Thank you.